So what is excretion? By definition, it is defined as the process whereby drugs and/or their metabolites are irreversibly transformed from internal to external environment. In simple terms, we can say that it is the process of eliminating or expelling waste matters from the body. It can be either renal excretion or non-renal excretion. Excretion through kidney is called renal excretion, and this is the important route of excretion. Excretions through organs other than kidney like the lungs, salivary glands, sweat glands, etc. is known as non-renal excretion. Now let's discuss renal excretion. Almost all drugs as well as their metabolites are excreted through kidney. And the functional unit of kidney involved in the process of excretion is nephron. Excretion through kidney occurs by glomerular filtration, active tubular secretion, and tubular reabsorption. This glomerular filtration and active tubular secretion increases the concentration of drug in lumen and hence facilitate excretion, while tubular reabsorption decreases it and prevents the movement of drug out of the body. Thus, the rate of excretion can be given by the following equation. That is, rate of excretion is equal to rate of glomerular filtration plus rate of tubular secretion minus tubular reabsorption. Glomerular filtration is a non-selective unidirectional process, and in glomerular filtration, the drugs that are not bound to plasma protein is excreted. So, the glomerular filtration of a drug depends on its plasma protein binding and renal blood flow. That is, glomerular filtration increases with increase in renal blood flow. This GF rate is normally, or glomerular filtration rate is normally 120 milliliters per minute, and this declines after the age of 50 and is low in renal failure cases. Tubular reabsorption takes place in the renal tubule, and it occurs by passive diffusion and depends on factors like lipid solubility and ionization of the drug at the existing urinary pH. In tubular reabsorption, non-lipid soluble and highly ionized drugs are excreted more. So changes in urinary pH affect tubular reabsorption of drugs that are partially ionized, that is, weak bases ionize more and are less reabsorbed in acidic urine, whereas weak acid ionize more and are less reabsorbed in alkaline urine. Tubular secretion is the active transfer of organic acids and bases by two separate classes of transporters, OET and OCT, that operates in the proximal tubule. Organic acid transport through OATP, that is organic anion transport polypeptide for penicillin, probenecid, uric acid, indomethacin, sulfonpyrazole, etc., and organic base transport through organic cation transporters for thiazides, amiloride, furosemide, quinine, cimetidine, etc. Active transport of the drug across the tubule reduces concentration of its free form in the tubular vessels and therefore promotes dissociation of protein-bound drugs. Thus, protein binding is not a hindrance for tubular secretion. If renal clearance of a drug is greater than 120 ml per minute, GFR, additional tubular secretion can be assumed to be occurring. Drugs utilizing the same active transport in tubular secretion compete with each other. Many drug interactions occurs due to competition for tubular secretion. Some examples are sulfenpyrrazole inhibits excretion of tolbutamide. Salicylates decreases tubular secretion of methotrexate. Let's see what is kinetics of elimination. The knowledge of kinetics of elimination of a drug helps to devise a rational dosage regimen and to modify that according to individual needs. Dosage regimen is nothing but the frequency of administration of drug in a particular dose. The pharmacokinetic parameter we are going to discuss here is clearance. Clearance is the most important parameter useful in evaluating the mechanism by which a drug is eliminated by the whole organism or by a particular organ. And this relates plasma drug concentration with the rate of drug elimination according to the following equation. Clearance is equal to rate of elimination by plasma drug concentration, that is dx, mathematically dx by dt the whole divided by c. We can define clearance as the theoretical volume of body fluid containing drug from which the drug is completely removed in a given period of time, and it is expressed in milliliter per minute or liters per hour. Drugs that are eliminated from the body follows either first order kinetics or zero order kinetics. Elimination of most of the drug follows first order or exponential kinetics. In first order kinetics, the rate of elimination is directly proportional to the drug concentration. That is, a constant fraction of drug in the body disappears in each equal interval of time. So, in first order kinetics, the clearance remains constant. Example is given, and if you plot a graph of plasma concentration versus time, we get a straight line. Now let us see zero order kinetics. We have seen that most of the drugs follow first order kinetics of elimination. However, drugs like phenytoin, tolbutamide, warfarin at low doses follow first order kinetics. But as the plasma concentration increases, elimination process gets started, and the kinetics changes from first order to zero order or saturation kinetics. In zero order kinetics, the rate of elimination remains constant irrespective of drug concentration. Here, a constant amount of the drug is eliminated in unit time. Please see the example. Clearance is more at low concentration and less at high concentration. And also half-life is less at low concentration and more at high concentration for zero order kinetics. Now let us see what is plasma half-life or T-half. Plasma half-life or T-half of a drug is the time taken for its plasma concentration to be reduced to half of its original value. Mathematically, it can be represented as T-half is equal to 0.693 times V by Cl, whereas V is volume of distribution and Cl is the clearance. Half-life is a derived parameter from two variables, that is volume of distribution and clearance, both of which that can change independently. So we cannot consider it as an exact index of drug elimination. For drugs that are eliminated by first order kinetics, T-half remains constant because volume of distribution and clearance do not change with dose. And for zero order kinetics, T-half increases with dose because this clearance progressively decreases as the dose is increased. Playto principle. Simple calculation shows that 93.75% of the drug is eliminated after 4 half-life. More than 4 half-life is required for complete elimination. So repeated administration of a drug at intervals shorter than this leads to drug accumulation. So a drug administered in equal dose intermittently at constant time interval will accumulate to a Playto plasma level or steady state. After the Playto is reached, drug elimination equals drug absorption during the dose interval. The figure shows the rise of drug concentration to a Playto or steady state level during repeated oral administration of a constant dose. Next, let's see what is loading dose. Loading dose is a single or few quickly repeated doses given in the beginning to attain steady state rapidly. It can be represented mathematically as loading dose is equal to Vd into target Cp by F, where F is the fraction of the dose administered, target Cp is the plasma concentration, Vd is volume of distribution. Thus, loading dose is governed by volume and not by clearance or T-half. Next is maintenance dose. Maintenance doses are smaller doses repeated at specific intervals so as to maintain plasma concentration. It can be represented as maintenance dose equals Cl into Cp by F. Therapeutic drug monitoring. This therapeutic drug monitoring is a process by which the dose of a drug is adjusted according to its plasma concentration. The adjustment is useful in the following situation: when we use a drug with low safety margin like digoxin, anticonvulsants, antiarrhythmics, etc. And if the individual variations are large like antidepressants and lithium, when potentially toxic drugs are used in patients having renal failure like aminoglycoside antibiotics, vancomycin, in case of poisoning. Deuterium is useful in case of failure of response without any apparent reason, and also to check patient compliance.